Our speaker obtained his bachelor's degree in chemistry from Harvard University. He was selected as the first African-American Rhodes Scholar from the state of Arkansas. After receiving that honor, he has worked diligently to make sure that there are others who follow in his footsteps. Our guest speaker obtained his medical degree from Johns Hopkins University School of Medicine. And after graduating, he focused his time, his attention, and his passion on helping eliminate disparities in healthcare based on economic status and eliminating disparities in healthcare for people of color. He is known around the world for his research in the fields of immunology. Now, I practiced that many times, doctor, I want you to know, but it didn't come out that time, and virology, and in finding a drug to fight HIV infections. Our speaker is highly respected for his work in the field of infectious diseases. He has received numerous awards and recognitions, including being elected to the prestigious National Academy of the Sciences. It is my pleasure to introduce the man who is currently being vetted to be a member of President-elect Joe Biden's elite coronavirus task force team. He is none other than the renowned and well-respected James E. K. Hildreth, Dr. James E. K. Hildreth. Welcome, Dr. Hildreth, to New Mexico. We are so excited to have you here, and we are turning over this platform to you because we can't wait to hear what you have to say.
Well, first of all, thank you so much for having me. What I'm going to do today is talk about the virus that we're also concerned about, talk about the pandemic as it currently stands, and then share some thoughts about the vaccine. And I'm currently serving on the FDA committee that will vote to approve the vaccines. So I have a perspective I think that will be useful. So the first thing I wanted to talk about is the virus that has caused us all this concern. The disease that we're worried about is COVID-19, but the virus that causes it is actually called severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. So that's the virus that causes the disease. And what you may not know is that the virus belongs to a family of 7 human coronaviruses, and 4 of those viruses have been infecting humans since the 60s, and they cause a common cold. They're very seasonal. We have to deal with them every year during the winter times. And there are 3 viruses in the family that have caused pandemics. SARS is a member of that family from 2003. MERS is a member of the family from 2012. And the difference between those 2 viruses and this one is those 2 viruses require that you make contact with an animal in order to become infected. In the case of SARS, it was bats. In the case of MERS, it was camels. The difference between those 2 is that those 2 viruses required animal vectors. In this case, we are the vector. We're giving the virus to each other. And that's the major difference between the previous coronaviruses and this one, is the ability to transmit the virus to each other. One of the things that's really significant about this virus that I cannot emphasize enough is that it's a truly airborne virus. What that means is that unlike some viruses that require you to cough or sneeze to transmit them, this virus can be transmitted by the simple act of talking in a normal voice with someone who's sitting with you or standing with you. And if that occurs for more than about 10 to 15 minutes, there's an excellent chance that the virus can be transmitted, because it does not require large droplets like flu does and some other respiratory viruses do. This one can be aerosolized just in the air that we exhale from our lungs. So one of the reasons why we are taking the steps to mitigate the virus in the way that we are doing is because it is truly airborne, and just talking to one another over an extended period of time is enough to transmit the virus. That being said, this is why we've advocated masks the way we have. And some people believe that the masks were being worn to protect, to prevent someone from transmitting the virus to others. In other words, if the persons with the virus were to wear the mask, the rest of us would be protected. Actually, the mask works in both directions. Whether you have the virus or you don't have the virus, either way, you are protected if you wear the mask. So that in the situation that we're currently in with so much virus around, it is prudent and required, if we're going to bring the virus under control, that all of us wear a mask. And the reason why that's important is, as I'll talk about later, the number of people who are pre-symptomatic or asymptomatic who can transmit the virus seems to be quite significant. And that being the case, masks are again imperative if we don't know really who it is that's transmitting the virus because they have no symptoms. But the major point is the mask works in both directions. It protects those who are not infected from becoming infected. It prevents those who are infected from transmitting the virus to others. So if we all wear the mask, it would have a very significant impact on the pandemic. Just as a quick reminder, when this all first started, the symptoms that we all focused on was fever, dry cough, and a couple of other things. We now know that the symptoms that might be displayed by someone who's infected is actually quite much broader than that. There can be a new loss of smell or taste. There can be diarrhea and some of GI symptoms that can also presage the virus coming on. So the list of symptoms is now much larger than it was before. And this actually makes sense because viruses are incomplete life forms. They have to get inside of our cells to replicate. And they do that through proteins that are called receptors. The receptor for this virus is all throughout our body. It's in the gut, it's in the kidneys, it's in the lungs, of course, it's in parts of the brain, it's in the testes. So the number of tissues that can be infected by this virus is actually quite broad. And that probably explains why the symptoms you get when you get infected can also be quite broad. The disease, COVID-19 is the name of the disease. The virus again is SARS-CoV-2. COVID-19 is a form of what is called severe acute respiratory syndrome. What actually happens is the virus binds to cells in our lungs, it infects the cells in our lungs, and therefore does damage directly to the lungs. But one of the other things that happens that's really important to understand is the immune response to the virus is so exuberant that the immune response itself does damage to our tissues. And part of the reason why that happens is because of inflammation. The cells that come into the lungs release chemicals called chemokines and cytokines. These chemicals then recruit other cells to the lung tissue, and those cells do further damage. So there are two aspects to the disease that are very important. One is the direct destruction of tissues by the virus. The other is the fact that the immune system itself, in responding to the virus, is adding on to the damage that we see. So a few words about, we talked about the virus, we talked about the disease, now let's talk about the pandemic. There are now more than 57 million people around the world that have been infected with this virus, and about 1.4 million people have died. So this is truly a pandemic, which by definition is a global epidemic. And it's one of the deadliest now in human history, having infected that many people and killed more than 1 million people. What's really sort of embarrassing, and there are other words I could use, is the fact that even though the United States only represents somewhere between 4 and 5% of the global population of the world, we have almost 20%, actually more than 20% of the cases. And the pandemic, quite honestly, has been handled very poorly on a national level. And part of that is because the national agencies that should be responsible for the response have been handcuffed by politics. And I will leave it at that. One of the things that I find quite remarkable about the pandemic is that the global scientific community has collaborated in a way that has not been seen before. Scientists who are working on other viruses, scientists who've been working on other things, put those things on pause, turn their attention to COVID-19. And the result is there are now thousands and thousands of papers that have been published on this problem, on the virus and on the disease. The other thing that I've not witnessed in my professional life is that the big drug companies themselves have collaborated as opposed to competing with one another. And so in contrast to the national leadership in responding to the pandemic, the scientific world and the medical research world have come together in a way that's very encouraging and gives me hope that we can do this. So what about the picture here in the United States? As of November the 20th, there have been an astounding 12 million cases of COVID-19 diagnosed in the country. That's approaching 3 to 4% of the total population. Now, if you consider some of the research that has been done, which shows that for every case that's diagnosed, there's somewhere between 4 and 10 cases that go undiagnosed. The actual number of people who've been infected by this virus probably is north of 60 million people. And you also probably know that we're now on a trajectory tomorrow or the next day to surpass 200,000 cases per day. Just an astounding number. More than 250,000 people have died of COVID-19 so far, and that number is rapidly approaching 2,000 deaths per day, which would be somewhere around, I don't know, several people dying per minute in the country. And the tragedy of all this is that tens of thousands of people could have been saved, lives could have been saved, if we had a nationally coordinated strategy to deal with the virus. One of the sort of profound challenges of this have been the disparities and the burden of disease from COVID-19 among minorities in the United States. If you look at what happened in China in the earliest days of the pandemic, considering that China is a racially homogeneous nation, and genetically homogeneous for that part. If you lived in China and you were older, if you smoked, if you had hypertension or high blood pressure, if you had asthma, cancer, or a number of other diseases, you were much more likely to get sick and much more likely to die. So it is no surprise that here in the United States, people who have those same conditions, older than 65, high blood pressure, diabetes, asthma, obesity, cancer, that they are actually dying at a much faster rate and getting much more ill than people who don't have those conditions. What that also means is a story that we've known about, some of us have been working on this story for a long time, or this problem, is that COVID-19 has disproportionately burdened and ravaged the Black community and brown community, such that in some places, 70% of the people who are dying are Black. For example, in Louisiana, early on in the pandemic, the ratio of African Americans dying to whites dying was 5 to 1, at least 5 to 1. And that story continues to repeat itself. The numbers have gotten slightly better, but it is still a persistent problem that if you live in minority communities, if you have certain conditions, you are much more likely to get severely ill and to die from this disease. So one of the things that has troubled me from the beginning, and I've been writing about this and pushing this idea, that we have taken what could be called a population approach to dealing with COVID-19. And that approach assumes that the risk is the same for all of the population. We now clearly understand, and we've actually understood this now since April, that the risk is not even across the population. There are certain members of the population who are at much greater risk than those who don't have those conditions, which means that if we don't take a more focused approach to this problem, those individuals will account for a large number of the people who are dying. What I mean by that is we should be focused on those who are most likely to get sick, most likely to die. Make sure we're doing adequate testing, contact tracing, and treatment in those populations. And doing so would actually save many, many lives. The approach we're taking, again, assumes that everyone has the same level of risk, everyone has the same chance of getting infected. We clearly now understand that that is not the case. So it's probably time for us to take a different approach to try to save as many lives as possible. So I want to now talk about vaccines, and vaccines serve the purpose of giving us herd immunity. And herd immunity is achieved when 60 to 70% of a population is immune to a pathogen, a virus. The term actually comes from agriculture. Many decades ago, when viruses were ravaging cattle and other kinds of agricultural animals, they noticed that once the virus had raced through that group of animals and the remaining animals were infected and now immune, that they were now no longer in danger of that virus because the virus could not be transmitted any longer, because sufficient numbers of those animals were resistant to the virus, having been infected and now immune to it. So the same thing is theoretically possible for COVID-19. We could actually let the virus, in theory, run through the population and kill all those who it's going to kill, make all those sick that it's going to make sick. And in theory, if immunity were conferred by infection, we could actually achieve herd immunity. The problem is that doing so would require about 250 to 300 million people to be infected, and millions of people would die. And clearly that's not an acceptable scenario. So vaccines serve the purpose of giving us herd immunity by making sure that 70% or more of us have been vaccinated and we are resistant to the virus. So in order for the vaccines in this case to be most effective and achieve the goals we want them to achieve, we got to make sure they work in the vulnerable populations. And again, that includes older individuals, individuals with certain conditions. It is also important that vaccine trials must include individuals who represent those vulnerable groups, older individuals, individuals with chronic conditions, and certainly minority individuals need to be part of those studies. The other thing is, of course, that vaccines must be demonstrated to be safe, because we don't want the vaccine to do harm, since we're going to be giving it to billions of people around the world.
Dr. Hildreth, you may now share your screen.
Oh, really? Wonderful. Okay, let me do that. Or try to do that. Let's see. Oh, great. Where are the slides? There they are. Okay, go to. Okay, super. So what vaccines are meant to do, what they're designed to do in this case is, if you look on the left-hand side, what viruses need to get inside of cells, as I said earlier, there's a protein in this case called ACE2 that binds to the spike protein of the virus that enables the virus to enter into the cells. What these vaccines that are currently being developed are designed to do is to create antibodies that latch on to the spike protein and prevent the spike protein from binding to the receptor. And this results in neutralization of the virus. And these antibodies are then referred to as neutralizing antibodies. There are 3 types of vaccines being developed right now for COVID-19 as part of what is called Operation Warp Speed. And that's an unfortunate name that I'll talk about in just a minute. So there are protein-based vaccines. What these vaccines consist of is we take the spike protein, we purify it essentially, mix it with an adjuvant that's meant to boost the response, and that gets injected into people to elicit the antibodies. The other approach that's being used is we take a common cold virus called adenovirus. We put the gene for the spike protein into this virus. We literally then infect individuals with this common cold virus that's been attenuated so it doesn't cause disease, but it delivers the payload. It delivers the spike protein into the body. An immune response is made, antibodies are made that will presumably neutralize the virus. The 2 vaccines that have currently reached the conclusion of phase 3 are a new platform in which neither the protein nor a virus is used, but we use the messenger RNA as the vaccine. Messenger RNAs are kind of like the working blueprint for proteins. In our bodies, we have genes that encode proteins, but in order for those proteins to be made, there's an intermediate kind of a working blueprint that's made. That working blueprint is messenger RNA. When messenger RNA gets inside of cells, it causes proteins to be made. The immune system sees those proteins, responds to it, and antibodies are made. So there are 3 platforms being used for vaccines, and there are 2 vaccines for each of these platforms that are being developed. This actually shows you the timeline that is being, we're seeing right now. There are 6 trials underway that are being started over a 5-month period. The reason why the Moderna vaccine and Pfizer vaccine are now ready to be presented to the FDA, they got the earliest start. They started in July. AstraZeneca started in August. You might recall that they paused that study in September. Johnson & Johnson's vaccine started in September. The Novavax vaccine, which is the one we're doing at Meharry, is actually going to start in early December. And then finally in November, the final 2, Sanofi, and the other one will start. Each of these trials is designed to enroll 30,000 participants. 15,000 people get the vaccine candidate. 15,000 get a saline injection. The goal or the endpoint comes when 150 cases of COVID-19 have been seen across both groups. So one of the things I'm often asked is, why has it been possible that in the span of 10 months, we go from discovering the virus to having vaccines ready for the FDA to approve? And there are 2 factors to share with you that have made this possible. One is the technology available to the scientists developing vaccines is really unprecedented. And I'll just give you one example of what I mean by that. The Chinese scientists published the genome sequence of the virus, I believe on January the 10th. In less than a month from that date, we had already identified candidates for vaccines for SARS-CoV-2, for COVID-19. And to put that in perspective, the discovery of the virus to the time we have typically a vaccine candidate ready to be tested can be a year, sometimes 2 years, and in a few cases it's been longer than that. So the fact that we're able to go from a genome to a vaccine candidate in 1 month speaks to the incredible technology that has been brought to bear on this problem. The other thing that you should know is, I'm an HIV researcher. I've been working on HIV since 1987, and I'm part of what is called the HIV Vaccine Trials Network. There is a vast network of institutions that have, for the last 20 years, been working on an HIV vaccine. We've not developed a vaccine, but we've developed an incredible network of organizations focused on the vaccine. So what actually happened is the HIV Vaccine Network was asked to pause its work and turn its attention to COVID-19. So this pre-existing infrastructure designed to develop vaccines was another reason why we're able to do this so fast, because we did not have to create a new infrastructure. We simply shifted from HIV to COVID-19, and that made the speed possible. Quickly, let me just share with you the exciting data from the first 2 vaccines, Pfizer and Moderna. Both of these vaccines use the spike protein as the target. Remember that that is the protein that allows the virus to bind to cells. They both require 2 doses. So you get the first injection, and then about 3 weeks to 4 weeks later, you come into the clinic and get a second injection. The really exciting news is that both of these viruses showed 95% or about thereabouts efficacy in blocking disease in people. And we know that because in the case of Pfizer, for example, there are 162 cases of symptomatic disease in those who got the placebo, but only 8 cases in the people who got the vaccine. The really good news is that there were 10 cases of severe disease in the placebo group. 9 of those happened in the placebo, only 1 of those happened in the vaccine group. So both of these viruses show a high degree of efficacy, and the really good news is that in addition to blocking even mild cases of disease, they both blocked severe disease extremely well. And they haven't released the data yet, but we know for sure that the vaccine worked in both cases. In older individuals, it also worked across ethnic groups and racial groups. So this is very, very exciting news. And the date has been set for review of the Pfizer vaccine. It's going to be in mid-December. And again, I'm on the committee that reviews the vaccines for approval. We expect that Moderna will submit its vaccine data in December or early January. So it is likely and actually probable that in January, there will be vaccines on trucks rolling across the country to be distributed to people. Right now, the order of immunization as it stands, as recommended by the committee at the CDC, is that healthcare providers will get the vaccine first, along with those who take care of individuals in nursing homes and assisted living facilities. Then those individuals with predisposing conditions, at least 2 of them, will probably get the vaccine next. And after healthcare providers, high-risk individuals have been vaccinated, then the idea is to get the vaccine to the rest of the population. So there are some major challenges to go along with the good news about the vaccines. One is manufacturing, distributing, and storing hundreds of millions of doses of vaccine will not be easy. There's also going to be the logistics of vaccinating 330 million people within a short time. And to back up to the storage, you may have heard that the Moderna vaccine is especially challenging because it has to be stored at minus 94 degrees or something like that, which is not your typical freezer. It's a specialized freezer to achieve those kinds of temperatures. So that's not true for the Pfizer vaccine, that's true. For the Moderna vaccine, that is not true. But that just points to one of the challenges that we'll have to deal with. We are trying to make sure, those of us who are involved in this process, that there's ethical distribution of the vaccines, i.e. we want to make sure that minorities are among the first to get it because we're most likely to get disease and to die. One of the biggest challenges that we're trying to deal with, honestly, is that there's a lot of vaccine hesitancy and mistrust of science and healthcare especially among African Americans. There are a lot of reasons for that. It's justified, it's well justified. Going all the way back to 1619, atrocities have been visited upon Black bodies in the purpose of research in this country. We often look to Tuskegee experiment as an example of that, and it really was a bad thing. From 1932 to 1972, 600 Black men were used as guinea pigs and trying to understand syphilis. And even in 1945, when penicillin was available to treat it, they were not given penicillin. It was so bad that a president of the United States had to apologize for it. But what people don't know is that because of Tuskegee, research involving humans was changed forever. Because of Tuskegee, we now have informed consent. We now have institutional review boards. We also have what are called data safety monitoring boards. So the level of transparency and level of monitoring of safety is really not ever been this high, but a lot of that is directly due to the response to the Tuskegee experiment. So I do want to just close my comments by saying that we're entering into a really critical time point in this pandemic. And it's really important that we take steps to protect ourselves and our communities. And you've heard it said so many times, and I'll just say it a few more times. Mask wearing by all of us is one of the best things we can do to protect ourselves. We can all be excited that vaccines are on their way. We'll be here, probably to the general public by next spring. But in the meantime, that's months and months of dealing with the virus. We have to wear masks to keep the situation under control. The other thing that's really important is I shared with you that the virus can be transmitted just by normal conversations. So it's important to still do the physically distancing ourselves from each other, especially if you're interacting with someone who's not part of your bubble, not part of your pod, who's not been isolating with you. It's really important. I can't emphasize enough how important it is to avoid crowds. I shared with you that for every case of COVID-19 we diagnose, there are several cases that are not diagnosed, which means there are a lot of people out there who are transmitting the virus without being aware they're doing so. And that's why avoiding crowds is so important, because crowds right now represent super spreader events. One person may come to the event with the virus, several people may leave the event with the virus because of all the reasons that I've shared with you. And if it's all possible, if at all possible, limit your gatherings to 10 people or less. And if you can possibly do it outside. And if you're going to be inside, it's really, really important that there's be good ventilation to keep the air moving in that place so you minimize the risk of COVID-19. And you've probably heard it on the radio and printed ads, et cetera. It's really, really important this season that we all get a flu shot. There are a lot of reasons for that. One is that the symptoms of flu and the symptoms of COVID-19, at least initially, are very similar. And so one cannot necessarily tell one from the other. The other thing is that it's entirely possible to get COVID-19 and flu at the same time. And since they both can do devastating harm to our lungs and to other parts of the body, it might not be such a good idea to have both of these viruses infecting you at the same time. So for all those reasons, we really are encouraging people to get a flu shot. And in the flu season, when there's going to be a lot of sniffles and runny noses and all that, it's really, really important that we get back to, because people have sort of dropped it, washing our hands frequently, protecting our T-zone, which is our eyes, nose, and mouth. When we touch surfaces that are contaminated with viruses and we touch our face, and it's instinctive. People do it hundreds of times a day. And that's why washing your hands multiple times a day is so important. And if we do these things, I think we can keep ourselves protected, keep our communities protected, which is really important at this time. So that kind of ends my structured talk, and I'd be happy to answer any questions that people might have. Thank you very much.